Hello and welcome to the operating room. My name is Lucas.
I'm Karam.
And my name is Steve Xydas.
Steve Xydas. And Steve, oh, I should probably call you Dr. Xydas, right? Dr. Xydas, where did you go for college and medical school and all of that?
Sure. First, I'll tell you, I did go to public high school, Herrick's High School on the North Shore of Long Island, which is where I grew up. I then went to Harvard College for undergraduate, and I went to Johns Hopkins Medical School for the medical school portion.
And then, did you grow up in Long Island, you said?
Yes.
And were you born and raised there?
Yes, I grew up first in Queens until I was about in 8th grade, then moved to Long Island, and that's where I was.
And is your family all from America, or?
Yes, me and my sisters were all born here, but both of my parents are actually Greek immigrants. So they were born in Greece, and they came here in the late 60s, early 70s.
Awesome. And what kind of doctor are you now?
I'm a heart surgeon.
Amazing. What did you study in your undergrad?
So interestingly, I knew I wanted to be pre-med all along, but rather than focus on one of the sciences specifically, I took my pre-meds, which were 7 or 8 requirements, and I focused and concentrated on healthcare economics. So economics was my primary major.
Awesome. And you do any sort of thesis or any subtopic in economics?
Yeah, the way I try to unify being interested in medicine and being interested in economics, I focus on healthcare economics, and I wrote a thesis on the Greek healthcare system, being Greek as well. I spent a summer researching that between my junior and senior year, and then through my senior year, you have the option to do a thesis. I opted to do that. It's 2 classes, the fall and then the spring, and wrote it on my experience and research on the Greek healthcare system.
Awesome.
That is very
That's really
interesting.
interesting.
And then you said you went to, where did you go for your undergrad again? I'm so sorry.
Harvard College.
Harvard. And then you went to Johns Hopkins for your medical school.
Correct.
Right? And then where did you do your residency?
I did internship, residency, and my fellowship all at the same place at Columbia Presbyterian in New York City.
Amazing.
Yeah, so very, very well rounded. When did you decide that you wanted to be a cardiothoracic surgeon?
I really thought a lot about it as even elementary school and middle school, and I knew it was if it was going to be medicine, I really want to be a heart surgeon. I had other interests, so I thought in college, if that didn't work out and my interests changed, I would do potentially something in economics and business. But I knew really from an early time, in elementary school, that I really felt I wanted to be a heart surgeon.
Awesome. I know you mentioned you did the research in Greece. Did you do any other sort of research in undergrad or med school?
Yes, in undergrad, I did work at Harvard Medical School through the school years and one summer, and I did research on chick embryos. There were specific heart genes. There's a gene known as the Timian gene, where mutations in that gene can lead to a lot of defects during development in the heart. And we studied that and really showed that it was a very important gene in heart development.
And does that gene only apply to just chickens, or did you just do the research on the chickens? Or does it also apply to humans too?
It was chick embryos, and there are definitely a lot of parallel genes in humans, and so we drew some of those analogies and hope that it would then translate into new therapies in humans.
Yeah, that's really nice. And did you do any other research besides that, or did you just primarily focus on that research?
So that was during college. I did do a little research even in high school. I went to SUNY Downstate in Brooklyn a few summers doing research there, and I participated in the Westinghouse competition in high school, and I was lucky to be a semifinalist. I did.
Can you elaborate on what that Westinghouse competition is?
Sure. Westinghouse, which is now, I believe, a different company, and I do think the competition still exists. It's a competition among high school students who do research projects in various fields, and people 50 states, and it's a national competition just to pick, sort of the winners of, the best research. So there's semi-finalists and finalists. I was a semi-finalist.
That's awesome.
Congrats.
Amazing. In medical school, was there any sort of class that you gravitated towards or you found like really interesting that kind of changed your perspective? Something like that?
Oh, very good question. Given my background in healthcare economics, in medical school there are a few classes like epidemiology where you study sort of healthcare on more of a systems perspective and healthcare policy. So I really liked those classes, enjoyed those classes a lot. It's sort of very generic, sort of your classes that you need to take in first and second year. First year, sort of a lot of the basic science, and then second year is more of the physiology and pathophysiology in different organ systems. But as a surgeon, the things in general that people like are things like anatomy, where you really study where things are, and you really want to be good and very interested in that. And that's where you work on the cadaver starting in your first year of medical school. And when you're cutting into the chest and the heart, that was really very, very interesting for me. And it sort of solidified what my initial ideas of wanting to be a heart surgeon. The other things definitely through second year, and when you're exposed more to the different organ systems, when we studied all the systems, for sure, that's where things really solidified that I like, the heart and the things that go right in normal physiology and the things that go wrong in pathophysiology. And those are the things that really drew me, much more into the field that I'm in.
And did you get into a lot of debt because you went to a lot of great schools, and did you accumulate a lot of debt or?
Oh, good question as well. I was pretty fortunate in the sense that, yes, I did have loans for both college and medical school, but I did qualify for financial aid in college, and I also received some scholarships, academic, from various sources. One was sort of like through Greek societies, like there was Hellenic Times, which is like a publication in New York based, which gave out scholarships in different Greek scholarships. And then in medical school, similarly, I did have loans, I did have some financial aid, and it was a combination of all those things. So I did come out in debt. By today's standards, those sums were luckily modest, if you can call $80,000 or $100,000 modest. It is modest by today's numbers, but those numbers, remember, with inflation, translated into bigger numbers. But then you sort of chip away at that. During internship and residency, I would say is the toughest time because you're earning enough to have a place and be independent, but it's hard when you start making payments for your school loans. And I did defer it for a bunch of time during internship and the early residency years, but then I started paying them back. And I think that's important, because the earlier you start paying it back, the earlier you're done and finished with things. So me and my wife had educational loans, and then luckily once you start working, as intending, within say 3 or 4 years, we were able to pay those off.
Oh, only 3 or 4 years?
Wow. Correct. I mean, and it's just a matter of your priorities, like how much you want to be done with that. Our sort of strategy was to rent a little bit and to get rid of that portion, so that then when you have like a mortgage and a whole new set of loans, that that was a clean slate from a debt perspective otherwise.
And where do you work now?
I work now at Mount Sinai Medical Center on Miami Beach. So for the first 7 years or so of my my work, I worked at Morristown Medical Center up in New Jersey. But after 7 years, we completely changed gears and moved completely from New Jersey down here to Miami Beach for this work opportunity. And the big difference was that I was able to, be chief of the division. So that's what brought me down here, that I was able to transition from, being a heart surgeon in Morristown, but one of a group of surgeons, to being the head of my division and being in charge of heart and lung surgery at Mount Sinai Medical Center in Miami Beach.
So as the head, do you do a lot of surgery, or are you mainly just making sure everybody's playing their role?
Oh, that's an excellent question, Lucas. So, at a lot of places, it may be more administrative, but in every hospital is different, and every division is different. Mine is very hands-on, so I still do a lot of heart surgery, which is really what brought me into the field, and so I'm very happy to play a busy clinical role in heart surgery and seeing patients, but in addition supervise the division and sort of not only do a lot of the recruiting and hiring, but really want to be on top of the outcomes on all the patients in both heart and lung surgery, in a lot of the administrative roles in the hospital.
So do you prefer like a more administrative role or more of doing the actual surgery?
For me personally, and it may change over time, I really enjoy the surgeries. The things that really drew me to heart surgery initially absolutely apply to why I love doing it every day now. And those are that you see a heart, and generally the heart is sick, from whether blockages or valve problems or tumors or other diseases. And when you operate, generally you get a lot of instantaneous feedback from the heart. When you do a good job and you reverse those problems, generally the heart is very happy and goes from being sick to being and functioning well. Where things only go so-so in the OR, then it can be very rocky. And so it's sort of like very quick feedback. So in different fields, like say in cancer, for instance, it may be that you start a therapy and you don't know the results of those therapies months or years or even a decade later. With heart surgery, sort of that feedback loop is very quick. Say in medicine, like a lot of things that are preventative, like treating high blood pressure to prevent heart disease or other problems later, it may be again sort of decades that you don't get that feedback. So in heart surgery, good or bad, the heart lets you know, is the way I like to think about it. I think that's mostly true.
That's amazing.
So do you have like any kind of like favorite cases maybe in your surgery career?
Yes, I think really in different fields, you're trained to do a lot of different surgeries, or you're trained to treat a lot of different problems, but you develop a focus on a specific field, and that's what makes you really tick, so to speak, really draws your attention. And over time, generally, you become really good at that, and then patients with that more specific problem really all gravitate to you because you develop that reputation. And from patients, but also from other doctors who are diagnosing these problems, and then sending that specific patient to you. So for me, it's aortic aneurysms. So aneurysms are where there's weaknesses in the aorta. The aorta is the tube that supplies blood to the whole body, and aneurysms can be in any part of the aorta. I'm a heart surgeon, so I fix aneurysms near the heart, near the aortic valve, near what's known as the aortic root, where the aorta takes part, starts at the intersection of the heart and the aorta, and it can span up into the neck. So those aneurysms are really my area of focus and what I've developed a lot of expertise in. And I follow a lot of patients with aneurysms of various sizes, some of whom need surgery, some of whom don't at this point. And then you follow them over time to keep them safe, because aneurysms can rip or rupture. So there can be emergent situations where you're operating, but the bulk of things are just elective, where you see the aneurysm growing and then you decide to operate to keep the patient safe, to prevent that sort of lightning strike, that very catastrophic event of a dissection of a rib.
Amazing.
And what was it? Oh my god, I forgot what I was going to say. So is that the main thing that you do, or is there anything besides that surgery, besides working on aortic aneurysms? Is there another case that you love doing, or anything that stuck out to you?
Yes, in heart surgery, we do a ton of bypass surgery. Bypass surgery is sort of more the plumbing of the heart, where you're reestablishing good blood supply to the muscle. And the way you do that is if there's a blockage, you're making a bypass, a detour around the blockage and plugging in into the heart artery past the blockage. So that detour bypass is sort of the plumbing where you do 1, 2, 3, 4, 5 bypasses in a heart. And we do that very commonly, and that's something really that I enjoy a lot. I do a lot of valves. And my focus is also minimally invasive. Conventional heart surgery requires open heart, a big cut in the middle of the chest to divide the breastbone and bring it back at the end when we're done. But I do minimally invasive surgery, so through a small cut, working in between the ribs to replace the aortic valve, or on the side to repair or replace the mitral valve or tricuspid valves. We've now have moved that field forward where we're operating on 2 or 3 valves, all minimally invasive from the small incisions. And I really enjoy repairing valves as opposed to replacing it. So a lot of times, where appropriate, the heart likes its own valve better than a replacement. So it's harder to repair a valve than to replace it. And so you get good with different techniques of repairing the mitral valve or the aortic valve where there's leakage.
Amazing.
And do you have any favorite patient interaction that you've had? Any patients that like stuck out to you that you just always remember them for something?
Yeah, there are a few over the years, and most of them are where their condition was very life-threatening, and patients come to you and in heart surgery, where they're really, really sick, they're in a bad spot, and they really look to you to do the best you can for them. And a lot of times they really understand and get a good grasp of how life-threatening things are. And I think where it's really life-threatening and then it goes very well, that it's a major impact and it really leaves a very deep impression on them, for you, and you really have that patient bond and family bond that changes you. I keep a file in my office where if you get like thank you cards and things like that, or letters, and I put it in there, and just sometimes, like, if you have a bad day or a bad outcome, and you're feeling down about what you do, I do go back to that folder, and I think that keeps you really grounded about all the other people that you've really helped and made a big difference for. And I think that really can affect you. And there's no question that in this field that's the case, and it can be the case pretty much every day, or once a week, or definitely at least a few times a month, where you're really operating on someone who's quite sick. So I think more specifically, what comes to mind is, sort of a grandmother type of sort of matriarch of her extended family who came in with an aortic dissection that ripped, that life-threatening problem. She didn't know that she had an aneurysm beforehand. And a lot of times it's sort of undiagnosed until it's too late. And so she came in with this rip, and in fact, had like almost no blood pressure. She was really out of it. I met her, and it was really hard to even have her stay awake for me to, ask her questions. She actually was suffering signs not only of the heart, but also of a stroke, because she couldn't move her one side, so that this rip had progressed and gone up into the neck, and really she was in a bad spot. And so very quickly you meet them, you get to know their acute issues, you scan them to really understand the problem, where the rip is. We have to do this in a very time-sensitive way, very quickly, within an hour or so upon her presentation in the hospital. And then she went immediately to the OR. And those hard discussions, you really have to involve their families, because they're not really able to have a very long conversation with you about where they are functionally, and you have to rely on their families to really fill those parts in. And yes, she was very functional until an hour or two before she presented to the hospital in this state. and she went immediately to the OR, and it was a very complicated rip from the heart all the way into the neck. It was about 6 or 7 hours to correct that. And then in the ICU, you can't go from that to something where you're completely awake and alert. You have to leave that patient sedated to really keep control of the situation every way you can for the first few hours post-surgery. And so it took a while in the ICU, but then she came through, and we were very lucky to see that she was moving that side of her body that she wasn't able to move before. And she came through, and it was a few days in the ICU and about a week or 10 days in the hospital, but she really rallied, though she was over 80 and a pretty frail and elderly patient.
And was that your longest surgery you've ever done?
No. Over time, particularly in heart surgery, you tend to operate on, multiple valves sometimes, multiple problems, which can take a very long time to fix. So I've done operations, though these are rare, that can be, 8, 9, 10 hours. Generally, those are patients who've had heart surgery before. And so if you have to do heart surgery a second or third time, say they've had heart surgery 10 years ago, different place, and one valve was a problem, or they had bypass surgery, now they have 2 or 3 valves involved. So if you need to do second time surgery and it's multiple valves and bypasses and an aneurysm, and so you're doing multiple procedures, that's where it can be a pretty extensive time for surgery. Generally, that's all expected, and you know that, you prepare the patient, and you really optimize them, meaning hopefully have them come in as strong as they can be prior to that. You need to stop the heart on the heart-lung machine in order to be able to operate on valves. So if you cut into the heart when it was beating, trying to replace or repair a valve, it would be, bleeding at you. So you put the patient on the heart-lung machine, and it's an amazing pump that was developed in the 1960s. It's been very well perfected over many decades in every way. But that is what allows us to do what we do every day. So we stop the heart for a short amount of time, and sometimes it's a few hours if you're talking about multiple valves and multiple procedures all at once. But amazingly, then at the end of the procedure, you start the heart up, you rest the heart for a little bit, and then they're on their own. And generally speaking, well over 95% of those cases, they do very, very well.
So would you say that you're under attack, like you feel pressured with a time limit because of when you stop the heart, you have to start it back again in a specific amount of time? Or do you feel that you have plenty of time to perform what you have to do?
That's an excellent question, Lucas. So it's a combination of those. So you want to work efficiently, and time is definitely very important, but you want to do a very good job or a perfect job. So you can't cut corners, and you have to get it right the first time. Occasionally, you don't get it right the first time, and then you need to stop the heart a second time in order to re-repair a valve or aneurysm if there's a problem. And that's not a good spot to be in, because the heart can tolerate being stopped for a fair amount of time as long as you prepare it and do that operation well and efficiently. Where you have to stop it a second time, then it's a second major stress. So it really, you want to get it right that first time, but you want to work efficiently. So it's really a balance where you want to work quickly enough that, the heart is fine, but that you don't, make a mistake that then means that you need to redo any portion of what you did. But time is very important in heart surgery. A lot of times in other fields, like cosmetic surgery or general surgery or breast surgery, things are not generally very time sensitive. You don't want to be operating all day for something you've done in an hour or two, because the patient might be sicker or more swollen or more stressed than they would need to be otherwise. But in heart surgery, it's much more dependent on time. But it's been very well perfected. You know how long the heart will tolerate. It's not that you're just stopping the heart and operating as fast as you can. You give the heart an oxygen-rich solution, what's known as cardioplegia, which is cold, and it also is high potassium, so it stops the heart. So this cardioplegia is cold, it's high potassium, And what it means is the heart's stopped, the heart's empty, the heart's not beating. So it's using like 5 to 10% of its normal metabolic load. And that will protect the heart for say 30, 40 minutes. During the conduct of your operation, every 30 or 40 minutes, you will give another dose of that cardioplegia. But that takes time. You need to stop what you're doing for 3 or 4 minutes while you're giving it. So you get the sense that you want to work quickly, but then you have to stop. You give an additional dose, and you may give multiple additional doses if you're doing multiple valves or something that's very complex.
So do you feel that you're like under a lot of stress or pressure when you do these surgeries?
And do you like that? And if you do you like that pressure and that stress? Because there's some people that enjoy, that like
The
stress
adrenaline.
and like the adrenaline. Or
Yes, and I think people in specific fields in medicine like that adrenaline or drawn to that adrenaline, and yes, absolutely. That being said, you're doing this multiple times a day generally and multiple times a week, and so you get very good, and it becomes extremely routine. So we do bypass surgery, do valves, we can play music, we can talk about different things in the operating room. So it's not like it's, constant, stress. You definitely work efficiently, but also when you do things a lot, you sort of develop a lot of rapport between you and your assistant. So you almost don't even need to discuss what you're doing. You know the steps so well in and out that it's sort of like a dance that playing a song, if you're a musician, and lots of different analogies, but you do something more than 10,000 times, you can sort of do it with your eyes closed and in the dark, it's just very much second nature. And then, of course, when then the critical portions or something is different than what you expect, absolutely, you stop, you're not talking, you're really, really focusing on what's going on, and you fix that issue, and then it's right back to being on a routine course.
And what music do you like to listen to when you're?
That's a good question. So I did, based on age, everyone has sort of different generational stuff. A lot of times it comes down to what you grew up liking. So we do play a lot of 80s music in my OR because, I was just, born in that time. I was born in the mid 70s. So, the 80s is what I really like. But I do, like playing a lot of the Rolling Stones and a lot of Rolling Stones radio and things like that. So we try to mix it up, and of course a lot of more recent stuff. Like some people play only classical and things like that. I do like classical once in a while, but I would say something more upbeat that keeps the operation going. So no elevator music.
Have you grown close with your team as a result of all the work?
Absolutely. If you can imagine, you're spending a ton of hours with the people in the OR, and it's not like there's 10 different people at every role. And of course, it depends on the size of your hospital and the size of your team. But for us, it's like 2 or 3 people in every role. So 2 or 3 different assistants, 2 or 3 different people who run the heart-lung machine. Maybe 5 different anesthesiologists who do 90% of my cases. 2 or 3 scrub techs who are handing you the instruments. Maybe 5 or 6 nurses who are doing various roles in the room. So it's a pretty small team, and so you really are spending many waking hours with these people, and really develop very strong friendships. All about their families, all about sort of their tendencies. When they're happy or not happy, or grumpy or not grumpy, or hungry or not hungry. You just develop very good understandings of each other over those many waking hours.
Yeah. And do you think that these long hours, does it take you away from family, or do you think that it interrupts your family life? Or would you say your family life is pretty smooth and you enjoy everything the way it is?
Excellent question, and I think definitely one of the big take-home points is in medicine, the different specialties and the different places you can work, because even within one specialty, every job can be a little bit different. So that work-life balance can be very different. So it could be, being a pediatrician or a general medical doctor, being all office-based, versus all hospital-based, like, and specialties like mine. A lot of emergencies and, nighttime activities or weekend activities, or it could be all completely planned, 8 to 5, Monday to Friday. So there's a lot of different variations within specialties. So in heart surgery in general, yes, it is a hard work-life balance because you can't do heart surgery sort of like so-so. You have to really do it a lot. You have to be really focused. You have to be really disciplined in order to do it well. I would say that the toughest time was residency in general and fellowship. Fellowship more than residency, like work hours, I'm again of a little bit of a different era right now. There's like rules about how many hours you can work and things in residency. I was sort of at the time where there wasn't those rules, or not rules that weren't really adhered to a whole lot. So we were working very, very hard. So every third night you would spend the whole night in the hospital, work the entire next day, and then come home. The good parts were you saw a lot because you were there a lot and you learned a lot. The downsides are, you're always tired and it's all like just about survival mode when you're home. It's just like eat and go to sleep and like rest, and very tough time. Same with fellowship. The first few years when you're in attendings or on your own, you have stress in a different level because you don't really appreciate how much your attendings when you're a resident or fellow are helping you, but they help you in ways that you don't always really appreciate. So in surgery, a lot of it may be like the decision making about who goes to the OR and when they go to the OR that you may not always necessarily get a good grasp because you're so focused on learning all the different types of operations that those little details are hard to always learn, and you may not spend as much time seeing the patients before surgery. The attending was sort of doing that on his own or her own. So those are the things that stress you out more as an attending those first few years. Plus, you don't have a reputation. Nobody knows you. So you want to be extra diligent, extra available, extra on top of everything to sort of build your reputation, build your practice, and build what you have. So that's a different type of stress, though your hours are less. Long-winded answer to just say, the first 5 years of attending life, at least in heart surgery, and for me specifically, were really rough. But you need to find that balance. And now being, say 15 years out, it's a lot easier. It is also a little bit easier where you have partners, and the general trends are like the newer, younger guys see a lot of like the emergencies and the sickest patients, and are doing exactly the role that I was describing, in those first 5 years. And then when you're more established, you start seeing the patients who come in more electively, and that work-life balance becomes a lot easier later.
Nice. Awesome. So speaking of like long hours and stuff, what would you say are your favorite things and probably your least favorite things about being a heart surgeon?
I would say the work-life balance, would be the toughest thing, the biggest negative. And everyone can deal with it differently. I think a big component is, the choices you make in your family life. Who your partner is. That can play a big role. Someone hopefully who is very supportive of that. If you're both have very, very hard work-life balances, then you need a lot of help at home, or you might make decisions not to have a family or things like that. Me and my wife, we were both in medicine, and I think that brings a lot of understanding of what sort of that balance is like. My wife is a nurse and an ICU nurse, and we did actually meet in the hospital many, many years ago in New Jersey. We had four girls, and we had kids very early on, sort of during the residency and the fellowship years. So that balance was hard. But Jerry's schedule, as a nurse, you work very hard, but it's like, usually 3 or 4 shifts a week. So there were days where she wasn't working, which helps a lot. And then we had a lot of family around for those other days. And then as we had more kids, Jerry went to per diem, meaning that instead of working, full schedule, she worked less. And now, for the last few years, she's not been working. But definitely needing to make good decisions about how to structure your family life, and also making time, because birthdays and activities and holidays, those are things that are hard to get back. But in general medicine, there's nothing that says, oh, it's a holiday, therefore people don't get sick. So it's always going to be, an area where you may not be around for Christmas or New Year's or Thanksgiving or birthdays, and hopefully your family understands that, and you try to be as good enough, good a parent as you can, and a husband as you can, or a wife as you can, so that when you're not there, people remember the good times.
And have you ever had any patient interactions that made you think that maybe I shouldn't be pursuing this medical career or anything like that, that just steered you away from becoming what you are now?
Another very good question. And patients aren't always understanding, and families may not always be understanding. And there are going to be situations where patients or their families can be extremely difficult. Sometimes they can really stand in the way of patient care. And those are the things that are hard. Luckily, it's the vast minority of patients. But, maybe if it's 5%, those situations are tough, and sometimes the patient and the families don't have good relationships, or maybe the patient's families are just really difficult, and those are not the very fun patients to see, care for, or operate on. And it's not just heart surgery, it could be anything in medicine, and you just have to develop a strategy for that, and that's going to irritate you, no question about it, and it's just a matter of how you deal with that. And what you don't want is to be angry back at families or patients, and you have to sort of remember that the patient's sick, and that can throw them off, and it can make them not nice, or it can make them grumpy, and sometimes heart problems are related to bad choices the patients make, but doesn't make them a bad person, and you have to have a strategy on how to deal with that. And at the end of the day, you just want to be able to say, I did the best job I could for every patient, and I treated every patient the same and worked really hard to do that. But at the same time, you have to sort of respect patient decisions, and if they don't want heart surgery and you feel they really need it, your job is not to be, a parent. It's not the paternalistic in medicine. And a few decades ago, that's the way it was. You would tell the patient, this is what you need, and that's it. But that's not the way medicine is now. You really want to counsel that patient about what you think they need and why they need it. You need to tell them about alternatives, like, okay, medicine only is an alternative, and why you may think that's not a good option, or some other options, and then they need to make the choice for themselves. So that's sometimes hard, where you really feel someone needs something and they don't want it, or even worse, they wait and they get really sick, and then right when things are really, really bad, then they come back to you, and they say, now I want heart surgery. And then sometimes you have to just say, I know you do, and I know you needed this, and now, unfortunately, it's too late. What you don't want to do is provide fetal care. In other words, you do heart surgery and they're going to die, whether you do heart surgery or not. And if that's true, then you shouldn't do it, because all you're doing is adding an incision on their chest when they're dying anyway, and that's not a good spot to be. So those are the really tough days where you have to say no and turn people down. But a lot of times it is the right thing to do.
Have there ever been any cases that that have put you down because it didn't go the way you wanted?
Yes, and that too is how, if you're okay dealing with that, can very much change what field you should be in. In this field, say there's a 2 or 3% expected mortality rate, and you do a great job in your observed to expected mortality is less than 1, meaning that people you operate on die less than they are expected to based on data throughout the US. So you're doing a good job, but it doesn't change that you're going to have a mortality rate of 1 or 2%, and if it's expected to be 3 or 4%, that means you're doing a great job. But that means you're somehow going to need to cope with, losing people. On the flip side, though, if you don't operate on those patients, they might have a 30 or 40 or 50% mortality risks, and you see that when patients say thank you but no thank you, and then you see them die, and they didn't go through heart surgery. So those are tough days, and the heart, and especially in sick patients, you could do what you think is an absolutely perfect job and they die anyway. And those are the tough ones. You're going to make mistakes, and then you're going to feel as if you played a role in that death, and that's the case. And that too is not for everybody, but again, you need to have a personal strategy so that doesn't affect you. And it might be the first case of the day, and then you need to get right back in there and operate that same day or that same night or the next day. And for me, I describe sort of having that folder and taking out things that you look at that reminds you and keeps you grounded. Or another strategy, and I was lucky enough at Morrison, my first job, it was a very big surgery practice, so there were multiple partners, and as a new person having to deal with this, there were older great mentors who helped me through this. And one of my partners would tell me, when you have a day like that, take out that folder or just go around the hospital and see all the patients you've operated on. And you see how appreciative they are, like instantaneously a few days later when they feel good. Patients are very, very appreciative, and that's what keeps you grounded, and you just have to remember.
That's beautiful. Wow. That's really nice. Do you have anything else? No? Okay. Do you have anything else you want to add maybe?
I think, always like at your phase and thinking about medicine and deciding you're interested in medicine, I think, one of the great things is just the diversity in the roles in medicine. And it's a great field, and the good parts are we want to keep an open mind, and then you're pre-med, and then you're in medical school, and you might have very set ideas about what you like. The hard part is knowing that you're going to like that field at the end of the day. So keep an open mind, and there's different roles and different, work-life balances at the end of the day in different fields. So keep an open mind about that. And you might make the wrong decision about the field that you choose. And sometimes people stop and go back and start an internship and then change gears instead of surgery going into medicine, from medicine to go into surgery, from anesthesia to go into surgery, from surgery to go into anesthesia, just as examples. And you don't want to put in all that time and effort and at the end of the day be in a field that you don't enjoy. And so it's okay if you start something and it's not what you expected, but you want to change gears and you want to be happy at the end of the day, even if it means a little more time to get there.
And do you have any advice for future cardiothoracic surgeons?
Yes, I think, you want to really commit to being lifelong learners. And that's another great thing about medicine is you can't just learn the topic and then practice medicine that's 40 years old, because you'll be a dinosaur and your patients won't get cutting edge medicine. So you need to go to conferences, you need to be committed to really be at the cutting edge of what's happening in the field and move the field forward and do your own research, and you very quickly sort of develop a lot of experience that helps guide, you know, how you treat patients, and that changes, and it changes this year versus last year as things in technology improve. So that's the really neat thing, and it keeps you very interested, but you can't just do it like, you know, it's great to have hobbies, but you have to also keep learning and wanting to read articles at night and when you're tired, but you know, on your free time on the weekends and things. You go to conferences, but you can quickly get up to speed on what's going on.
Well,
Thank you so much,
Yeah.
Dr.
Well,
Xydas.
super
this is great.
information.
No, great information, great questions, and I really wish the best of you and your future career goals. And any questions that come up, I'm very reachable, approachable, and we can put out my contact info for anyone listening to the podcast to ask, you know, questions in the future.
Wonderful. Thank you so
Thank
much.
you so much. And thank you for watching if you did sit through this. And yeah, well,
Bye,
bye.
guys.
Bye-bye. Take care.